somber scene indeed as 14 fallen soldiers return home to their loved ones. That's later. But first, let's get into that story I've been promising you throughout the show. The National Health Insurance is aimed, according to the people who are pushing for it, as a way of utilizing our health resources better, but fundamentally as making healthcare more equitable and more accessible to the poorest people in our country. The people who have just put out the document we're about to discuss say those exactly are their goals too. But the Universal Healthcare Access Coalition, which brings together the thinking of a large number of organizations representing health professionals, say this isn't the best way to do it. There's a better way. Let's welcome then, representing the UHAC, Dr Aslam Dasoo to 702 Drive. Dr. Dasoo, welcome and thanks very much for giving us your time. You have said that what the NHI does is centralize control of the healthcare system, but fails to address the fundamental problems. What are those fundamental problems in the view of you and your colleagues?
Good afternoon, John, and good afternoon to your listeners. So, short answer to your question is the problem that the health system faces is exactly one of poor governance, which has resulted in the public health system, the same system they say they want to make available to the poor, and which the poor patronize. Up to 80 to 90% of this population is dependent on it, has gotten decrepit under the same people who are now providing an option with NHI. That's the one thing. The second is that there's a private healthcare system which should have been regulated according to the Mental Health Market Inquiry, to which the private sector agreed, all of their recommendations, I should say, to which the private sector agreed, but failed to do so. And if you have a medical aid, you will have felt the pain of subscription increases for this. So there's your two big problems, all under the remit of the same people who are saying NHI is the answer, having failed to manage both the systems.
So one of the things that's very clear from what you're saying, many people will feel if you are challenging NHI, Dr. Dasoo, that most of your focus is on the private sector. From what I've read, that is not the case. You, for example, are pushing for improved cost control in the private sector around tariff negotiations, standardization of benefit packages and more. Take us through a little bit your suggestions in that regard, if you will, and tell us what you propose, why you believe they'll make a difference.
So just to add a very brief context, there was a health policy adopted by the first Democratic Parliament in 1997, and which was being rolled out and then summarily stopped by the incoming Jacob Zuma administration, resulting in zero healthcare reform from then onwards. They presented this thing called NHI, uncosted, unresearched, just with the idea that the government must control every bit of healthcare in the country. For the last 17 years, they've been retrofitting it with policy plugs and all these things, and have come out with this NHI Act, which cannot be implemented in any logical or rational way. So that's the context, right? We have been saying that there was no reason to stop the rollout of the plan, which was developed, in fact, in the 80s under the UDF and the South African Health Workers Congress, which promoted the entire object that they say this NHI promotes. It's utter nonsense. This is a sleight of hand. And even if they were to implement, if they tried to implement this, they couldn't. It requires tax increases, which is not possible. It requires legislative changes to about 12 acts of parliament and a couple of constitutional changes, which will take forever and a day to occur. It also requires a stepwise rollout that can take anything, and this is not from me, from the government itself, anything between 10 and 30 years. After having wasted 17 years, absolutely neglected the public health system, causing serial disasters in it, reducing its access, degrading its services.
Yes.
Now telling us that this NHI is what is good for us. So we at PHF, sorry, and I'll just stop after this.
Yes.
The Progressive Health Forum, then, who has been working on this alternative, well, not alternative, but the whole reform pathway that the country needs, collaborated now with the Medical Association, Private Practitioners Forum, and subsequently 30 other organizations which have joined this coalition to say this plan can be implemented now. Mm-hmm. It doesn't require any more money. It can occur within the current fiscal framework. It requires no major legislative changes. What it does need are two things. One is to fundamentally alter the governance of the public health system. At the moment, politicians make decisions that the executive should be making, and they make it remotely, and they control budgets, which results in no autonomy of facilities, which is completely the wrong way for health to work. Second, in the private sector, they have not regulated it. The private sector has now overheated. Even the members of the organizations in the private sector say so, and facing imminent market failures. Now, that's a situation they're trying to resolve by saying, we want to collect all the funding from medical schemes, from the taxes, put it into one fund, which no other country in the world does. And because people contribute voluntarily to medical schemes and won't contribute voluntarily to this fund, they will raise payroll taxes.
Right. So
to 8%. So there's your problem.
So one thing really caught my eye, Dr. Dasoo, and thanks for that very full explanation. Introducing a publicly sponsored commercial medical scheme as a competitive alternative to private schemes to, quote, strengthen healthy over unhealthy competition. And that's part, presumably, of a broader push to get more people onto medical aid. But how would that work? Because publicly sponsored commercial seems to me a contradiction in terms. I'm sure you've considered that and resolved it.
Yes. No. So just to put that in its proper place. So what we have proposed is a seamless funding of all healthcare, public and private. We have the tax funding now that you pay your taxes for, and it goes to public healthcare. The only problem with the public health system is its system of governance. If you fix that, you can fix it. You can rehabilitate it and make it reach the potential of a world-class public health system, which was always the plan, even with the damage of the neglect of the last 17 years. For the private sector, we have a problem because you have people on medical schemes and only very high income earners can afford that.
Right.
You have people who are also in employment, in receipt of income above the tax threshold, but who can't afford that. So they fall onto the public service. We're saying, no, we must make all medical scheme cover mandatory. So if you have a medical scheme at the moment, you have to stay on it. If you are employed and the schemes will continue providing the services they do, purchasing the healthcare. But for that missing middle, which is about 6 to 8 million people who actually are in receipt, and families of those who are in receipt of income, but can't afford medical aid, will now be put into a new medical scheme, some straightforward medical scheme under the Medical Schemes Act. So maybe that clears the confusion about publicly sponsored and commercial. It'll be a medical scheme under the Medical Schemes Act. No medical scheme is commercial. It's a mutual owned by its members, right? So now all of them, it's a very large risk pool. And it will then, like every other medical scheme, contract with service providers. For example, your private hospitals and your public hospitals that are accredited for services, private specialists, and GPs and so on. So, for example, if you are on that scheme and the contribution rate will be heavily subsidized because of its large risk pool, you may be able to go and see a private specialist, and if that specialist wants to admit you to hospital for any reason, the scheme's rules may indicate, okay, you need to go to this public hospital that's close by, and it's accredited, and you go there. And the private specialist follows you there and treats you there. We are talking about integrating the systems.
Right.
Because the way NHI does it is that it tells all the providers, it says to the public hospitals, which it owns, that it's now going to purchase services from the systems it owns, right? And it's telling the private hospitals and the private sector people, providers, that you will take a price that we will give you.
We'll have to leave it there, unfortunately. There's so much more to discuss, but thank you for at least setting the scene and sketching out the broad ideas coming from the Universal Healthcare Access Coalition. That's one of the steering committee members of that coalition, Dr. Aslam Dasoo, giving us his time here on 702. What are your thoughts about what you've heard?